Okay, so good evening all. Today we start head, neck, spine, and the brain. Again, as we mentioned before, the anatomy station is, or the anatomy question is 75 question out of 300. So it is the big bulk of the exam. Second, anatomy question is all or none. If you ask you the nerve supply of this muscle, so it's not controversy, not a lot of debate. Not like in the arterial blood gases sample or some physiology question. So usually the question is straightforward and easy, and actually collect a lot of number from anatomy question and from pathology question. Okay, so I start first, I read, maybe later some of the student read. 19 years old female is admitted with suspected meningitis. The house officer is due to perform lumbar puncture. What is the most likely structure first encounter when the needle is inserted? This is very common question because epidural is a common practice you see in surgery, although you don't do it, but you see in surgery. So it is important to know the surface anatomy, the layer in which the anesthetist inserted a needle inside the spinal cord. Of course, he asked the first encounter, so it means that what is the first layer after skin and subcutaneous tissue. Anyone have an answer?
Supraspinous ligament.
Yes, we have two ligaments in the front, the supra and the infraspinous ligament, and this is the first ligament you are penetrated during epidural anesthesia. Second question is about what is the correct embryology origin of stapes. Stapes is part from the inner ear bone, and it is important to know embryology of pharyngeal arches. Just to be easy, maybe difficult to remember, but in the answer sheet, I write the all pharyngeal arches, derivatives, and anatomy, and I send it to you after the lecture in the WhatsApp group. So S stapes is the second pharyngeal arch. If you remember, second pharyngeal arch is the arch supplied by facial nerve. So it is give is stapes muscle bone from inner ear, and also muscle called the stapedius muscle, and all muscle of the expression of the face, and the posterior belly of the gastric, and the stylohyoid muscle. Uh, what is important to know from this question, to know what is the topic is important for exam. It's not necessary you have the same question, but the same topic is usually fixed. In exam, the topic is repeated every time, have the same topic, but the question may be little change. For example, this question, 78 years old man is due to undergo carotid endarterectomy of internal carotid artery. Carotid endarterectomy is common to be done in Europe, in England, not much in Malaysia. It is done even if patient have a stroke, if have big embolus, so they done and usually done under local anesthesia. In most of the world is not common because usually big thrombus in carotid is not common except in European country. So which of the following nervous structure is most likely during dissection? This is important because in carotid artery, in carotid sheath, whether it is common carotid or internal carotid, have a lot of structure. So, for example, sympathetic chain is in the back, vagus in the back, but what is superficial and easy to be injured is hypoglossal nerve. Of course, if injured hypoglossal nerve, the tongue deviated to the side of the lesion. So if you are working in the right side, so the lung deviated to the right side. After that, what is important also is the jugular or the foramina of the skull, because foramina of the skull is a lot, and it is important to know what is structure transmitted through the skull foramina. And also in the answer sheet, I write a summary for all foramina of the skull. Of course, here he asks is not transmitted by jugular foramina because jugular foramina have many things, have many structure transmitted through it. So what is not transmitted in jugular foramina? Anyone have an idea? Just guessing.
Hypoglossal?
Yes, hypoglossal nerve, because hypoglossal nerve is not enter in jugular foramina. It enter in the carotid canal. So it is important also to know the foramina. For example, the important comment to be asked is middle meningeal artery, because it is passed through foramen spinosum, and is the only structure or only big structure in the foramen spinosum. After that, this is question regarding internal jugular vein. Which of the following statement is incorrect? Usually in exam, we don't have like incorrect question or except, but just this for teaching. And also it is important to know this is simple question, because if you answer one by one, it is important when study OBA or single best answer to know is the first one is correct or not correct, second till you reach the answer. For example, internal jugular is lie within the carotid sheath. Yes, correct, because internal jugular, common carotid, internal carotid within the sheath. Communication of sigmoid sinus is correct. Terminal part of the thoracic duct cross anterior to inserted in right subclavian. This is the first sentence is true. The terminal part of thoracic duct close anterior to it. But actually thoracic duct inserted in which part of the body, right side or left side?
Left side.
Left side. You know that all the abdomen, all thoracic duct end in the left, the entrance between the internal jugular and the left subclavian. So it is left side. So it is just, you remember it is in the left side. So it is easy to pick that C is the incorrect answer, or this is the true answer. Of course, hypoglossal nerve close related to it, and the bus near the atlas. Vagus nerve related within the carotid sheath is posterior. This is correct also. Okay. The next question, and is very common. It is important just to know. It is important to know that this is exam is MRCS is not for general surgery alone. It is for general surgery and for head and neck surgery. And from the next year, they already remove the MRCS ENT and become MRCS for all both general surgery and ENT surgeon. So the usually head and neck anatomy and pathology is very common to have an exam, because we have a group of students supposed to be head and neck surgeon. Next question about 18 years old man is cutting some plant when a small piece of vegetables matter enter his eye. His eye become watery. What is the following responsible for relaying parasympathetic neural signal to the lacrimal apparatus? So he asked about what is the parasympathetic. He need to ask about ganglia. In head and neck, we know that we have otic ganglia, submandibular ganglia, pterygopalatine, which is sometimes called sphenopalatine, and the correct answer here is pterygopalatine ganglia, which we called it sphenopalatine ganglia. Of course, some submandibular for the fiber go to submandibular salivary gland, otic something go to the ear, ciliary is something go to the eye. Next question, 7. Of course, if anyone have any comment, just stop me. It is applied surgical anatomy. He asked about 43 years old lady is undergoing total thyroidectomy for a large goiter. The surgeon decided that access may be improved by dividing the infra-strap muscle. Strap muscle is a sternohyoid and sternothyroid muscle. So which of the following should be divided? He need to ask, if you cut the strap muscle, you cut it from upper part and or lower part, and why? Anyone have an answer?
From the upper part, because we want to
Yes.
avoid the injury to the nerve.
Okay. Which nerve?
Ansa cervicalis.
Okay, so it is important to know the ansa cervicalis come from down up. So if you need to cut it, you cut it from upper half or upper part, not from the lower part, not from the middle. So it is just applied anatomy and simple question. 67 years old man undergo carotid endarterectomy and recover well following surgery. Post-operative, he complained of hoarseness of voice. Which nerve is most likely injured? Of course, we remember before Carotid artery is related to vagus, is related to hypoglossal nerve, is related to sympathetic chain in this area. So if the patient have hoarse voice, so most probably which nerve is injured? It is simple, like if the patient have a thyroid and malignant thyroid have hoarse voice due to vagus affection. Of course, in thyroid due to recurrent laryngeal, which is branch of vagus, but here due to the vagus itself, so it is affection of vagus nerve. Next question about 22 years old woman. He recently undergoing surgical excision of submandibular gland. She complained of weakness of tongue movement on the ipsilateral side to her surgery, but taste, pain, temperature, sensation is normal. So which nerve is damaged? So here it is important when you study this question to know pain and the temperature in front of the tongue or the anterior two-thirds of the tongue is by lingual nerve. Taste sensation by chorda tympani. The back of the tongue, taste, pain, and temperature by glossopharyngeal nerve. So this patient, sensation, taste, pain, temperature is normal. So as we mentioned, in the tongue, we have pain and the temperature by lingual and glossopharyngeal, taste by chorda tympani and the glossopharyngeal, and the movement of the tongue, all muscle of the tongue is supplied by. Anyone knows the answer except? Okay. All muscle of the tongue as a motor power is by hypoglossal nerve, except palatoglossus supplied by vagus. But roughly, most of the muscle of the tongue supplied by hypoglossal nerve. And again, injury of the right side hypoglossal makes the tongue deviated to the right side. Of course, it is the half of the tongue because we have right half and left half. Next question, 12 years old boy undergo surgery for recurrent mastoid infection. Post-operative, he complained of the altered taste sensation. So now he have something in the sensation. Which of the following nerve have been injured? So he needs nerve related to mastoid bone and affect the taste sensation. The nerve related here, of course, the answer, the taste is affected or transmitted by two nerves, glossopharyngeal and the chorda tympani. But from anatomical point of view, the nerve related to mastoid is chorda tympani, so the answer here is chorda tympani. So again, test the sensation of anterior two-thirds of the tongue by chorda tympani, posterior third by glossopharyngeal nerve. So innervation of the tongue also is very important, very common, and very easy. Next question, because sometimes you ask about, of course, in anatomy, we don't have much new guideline, not like trauma, not like surgery, but just this question, 43 years old man is due to undergo excision of submandibular gland. He removes the gland. What's the following new guideline for appropriate incision? In the past, for many years, so inside the submandibular, we make incision here, just in the line of the mandible to be cosmetic better. But they found that if you make this, maybe sometimes affect the marginal branch of facial and cause drop of the angle of the mouth. So nowadays they make the incision 5 centimeter or 4 centimeter or 2 inch below the angle of the mandible. It become cosmetic not good because it is appear in the neck, but it avoid injury of marginal mandibular branch of facial. So the answer here is transverse incision 4 to 5 centimeter below the mandible. In some books they mention in inch, so it is about 2 inch. In the past it is just one finger, about 2 centi or 1 centi, and nowadays it is 4 to 5 centimeter below the mandible. Next question. is a 5 years boy present with recurrent headache. As a part of assessment, he undergo MRI scan for brain. He demonstrates enlargement of the lateral and third ventricle. Usually, this is some sort of hydrocephalus, and this hydrocephalus usually due to the obstruction of the canal or the duct between the third and the lateral ventricle, which is, anyone know what is this duct called? Of course, it is not a foramina, it is aqueduct of Sylvius. The foramina is for drainage. And the easy way to remember that foramen Luschka in the lateral drainage and Magenti in the medial drainage. So the answer here is the aqueduct of Sylvius. The next common question is, what does the spinal cord terminated in neonate? So in neonate it is L3, in adult L1. So it is important to know that. In which space lumbar puncture is performed? Anyone? What's this space called?
Subarachnoid space.
Yes, so we inject the material in subarachnoid space. So you can find many questions related to the spinal cord and all this. This is the picture, by the way. If you can see here, you can see when you insert the needle apart from skin subcutaneous, we have two ligaments, supraspinous, interspinous ligament. And after that, we go to the space and they have ligament, another ligament called ligament flavum. And after that, go to the subarachnoid space. Usually, we put a needle in the level between L3 and L4, and you know that because it is the level of the iliac crest, of course, from the back. After that, again, one of the tricky question need to be remembered, need to be do many time. Which of the following is not pass through superior orbital fissure? We make it the reverse question because superior orbital fissure have a lot to pass. But the tricky here is just remember that optic artery is passed through the optic nerve, ophthalmic artery is passed through the optic nerve in the optic canal. So it's not in the superior orbital fissure. But you can find a lot of structure pass in the superior orbital fissure. So all the other inferior ophthalmic vein, abducent, trochlear, superior ophthalmic veins, all these pass through the superior orbital fissure. A 20 years old man is hit with a hammer in the right side of head. He died on arrival to emergency department due to extradural hemorrhage. So this is just he need to know in the extradural hemorrhage which artery is injured or which vein or which structure. Of course, this is easy. So which artery is injured?
Middle meningeal.
Yes, correct. So middle meningeal artery. But it is important if you found this question to know that middle meningeal artery is a branch from maxillary artery and is enter the skull through foramen spinosum. Sorry. So middle meningeal goes through foramen spinosum. It is a branch of maxillary artery, and it is important to know also maxillary artery is one of two terminal branch of the external carotid artery. The other branch is the superior temporal artery. So again, if you found this question, because this time he asked about the name of artery. Next time or in exam, he asked, so they found the middle meningeal artery is injured, from which foramina he enters the skull. So the answer is foramen spinosum. Or he asked from where originated middle meningeal artery. So it is maxillary artery. So it is important in this any question you found in exam the same question, but he asked another topic or another area. 21 old man is hit in hammer and sustained depressed skull fracture in the vertex. Vertex is the front of the skull. So what is the sinus at risk of injury? So this is easy. So what is this sinus?
Superior sagittal sinus.
Yeah, so easy. So it is a superior sagittal sinus. Yes. In relation to middle cranial fossa, which of the following statement is incorrect? So again, foramen rotundum transmit maxillary nerve, correct. Lacerum internal carotid, correct. Spinosum posterolateral to oval, okay, correct. Foramen oval transmit middle meningeal artery. What is your opinion?
Wrong. It
Wrong,
transmit the
because
accessory meningeal artery.
all right, good. So foramen spinosum transmit middle meningeal artery. Foramen rotundum and antomedial to foramen oval. Okay, so they usually, even if you ask about foramina, he don't ask about non-important structure. Usually ask about carotid, ask about middle meningeal, something have some important. Which of the following nerve is responsible for motor innervation of sternocleidomastoid muscle? Anyone knows the answer?
The accessory nerve.
Yeah, accessory nerve. And if you study this, it's better to know. So what is other muscle supply by accessory nerve apart from sternomastoid muscle? What is your answer?
The trapezius.
Trapezius. Any other muscle? No. Okay, so spinal accessory give only two muscle, sternomastoid or sternocleidomastoid and trapezius muscle. So this is why when you study through the OBA or the single best answer is better if you find question like that, so to know what other muscle supply. Because next time he ask you what other muscle supply or what is the nerve supply of trapezius. 60 years old female reported some visual difficulty. On examination, she noted to have homonymous hemanopia. So what is the lesion most likely to? Of course, usually the common question, not this question. The common question they ask about if the patient visual field is limited and he look like he looking in the tube, what we called it bitemporal hemanopia, and this bitemporal hemanopia, it is usually is due to optic adenoma or optic, not optic chiasm compression by pituitary adenoma. So it is important to know first bitemporal hemanopia. But in this question, he asked different. He asked about homonymous hemanopia. So homonymous hemanopia occur if the optic tract or optic radiation is affected. So it's a different issue. So the answer here is optic tract, optic radiation. But if this is optic chiasma due to pituitary adenoma, so it is bitemporal hemanopia. Of course, the common come in exam bitemporal hemanopia due to optic chiasma compression by pituitary adenoma. Pituitary adenoma can be benign tumor because it is adenoma, it's not a cancer, but it is affect the optic chiasma and cause eye lesion. Okay, next question. Following carotid endarterectomy again, a man noticed that he has weakness in the tongue movement. So again, as we mentioned, all muscle of the tongue supplied by hypoglossal except palatoglossal supplied by vagus. So the answer here is hypoglossal. This is next question is about eye lesion. An 18 years old male presented an accident and emergency with depressed skull fracture. He is managed surgically. Over the next few days, he complained double vision on walking, down, and reading. On examination, the left eye can't look, not look, can't look, down and medial. So he can't look down and medial. So this is trochlear nerve affection. But if the patient look, so the eye is looking fixed down and medial, so it is oculomotor. But here he can't look, so the answer is trochlear nerve. Of course, it's the easy way to remember that all muscle of the eye supplied by oculomotor, except CO4, so superior oblique by 4 nerve and the lateral rectus by 6 nerve. Okay. Eye movement also is important. 16 years old boy is hit in a car, sustained a blow in the right side of his head. He's initially conscious, but on arrival to emergency department, on examination, right pupil is fixed and dilated, and the neurosurgeon began immediate surgery. So what type of initial approach? This is question, of course, if the patient have trauma to the right side, he have weakness in the left side. But which pupil is dilated, right or left? Anyone got the answer? If patient have trauma to the right side, he have weakness in the left side, even paralysis. But which eye is dilated, right or left?
The ipsilateral eye. Right.
Eye, good, bagus, yes, correct. So the ipsilateral. So if the patient have trauma in the right side, have paralysis or weakness in the left side, but when I open to exposed, so the right pupil is dilated, so it is right parieto-temporal craniotomy. So it is right side extradural. Okay. Next question is not much tricky, but is important. What is the most useful test to clinical distinction between upper and lower motor neuron lesion of facial nerve? So that in upper motor neuron lesion, the patient can. This is also if the patient have facial nerve affection due to parotid, so the all half, the same site is affected. But if the patient have stroke and have associating with facial policy, because of the crossing in upper half of the body, so the patient can close his eye and can elevated eyebrow. So if the patient can close his eye or elevated eyebrows, so it is upper motor neuron lesion. But if unable, so most probably it is lower motor neuron region and the nerve affected is the facial and usually due to cancer in the parotid gland. Okay, or can be trauma, but usually cancer. So the answer here, this patient, he asked about in upper motor lesion, the patient can. So what is the patient can from all this movement?
Raise the eyebrow.
Raised his eyebrow and close his eye. Okay, so this is important. But other nerve like blowing, vaccinator, all this is affected in upper and lower motor neuron lesion. Next question, which of the following nerve is not contained within the posterior triangle of the neck? Of course, the posterior triangle of the neck is have a lot of structure. Like accessory nerve can, posterior in the deep, greater auricular behind the muscle, lesser occipital nerve in the back, but of course ansa cervicalis because it is supplies the strap muscle, the anteriorly, so it is not in the posterior triangle of the neck. So it's not from the content. Subtriangle of the neck is important also. So ansa cervicalis is anterior triangle, not posterior triangle. Which is the following cranial foramina bearing is incorrect. And again, we don't have question like this in exam, but just for training. Foramen lacerum internal carotid is correct. Oval mandibular nerve correct. Optic canal, ophthalmic artery correct, but optic canal and ophthalmic nerve not correct. Okay, because ophthalmic nerve is not passing optic canal, it passes in the superior orbital fissure. But the artery passes in optic canal. Optic nerve passes in the optic canal. Foramen rotundum maxillary is correct. So again, foramina of the skull is very important to remember. Next question, although it is long, usually in anatomy, on some question in exam, you can find big scenario. Like this 37 years old man presented with severe headache, photophobia, neck stiffness, Kerning sign is positive, midline lumbar puncture is performed immediately to determine the SCSF, pathogen is involved in performing the procedure? Which of the following structure is the first pierce in the lumbar puncture needle? So it is wise, of course, in exam we don't have anatomy followed by pathology followed by physiology. It is like mixed together. But if we found the question just scanning faster and found the answer is what is structure pierced, so it is not important to know this patient have meningitis and they need to take a sample. So it is not important from anatomical point of view. So first structure to pierce by lumbar, it is a repeated question, but here, as we see in the picture, he add supraspinous ligament correct, then interspinous ligament correct. So the answer is D. This question is easy, it's just anatomical landmark. What is the surface anatomy of external jugular vein? So as you see in this picture, we make a line between the angle of the mandible and the middle of the clavicle. Okay, so angle of the mandible and the middle of the clavicle. It is the line or surface anatomy of the external carotid vein. It is important for cannulation of it, sometimes for rapid venous access or central line. Again, I just repeated this question just to avoid misunderstanding. 50 years old man complained of recent diplopia. On examination, he is unable to look inward and downward, and again the answer is trochlear. This is why I think I have a picture, because if the patient looking downward and laterally and have dropping of eyelid and dilated and downward and laterally, so it is oculomotor affection. Sorry, I mentioned before medial, it is laterally, downward and laterally. Okay, so here unable. Here the patient, you see the patient, the eye is looking down laterally and down, and little, not much dropping of eyelid, so it is oculomotor nerve affection. Okay. This is the important of to see the question or previous exam question, just to know what is the important topic you need to discuss or what is the important topic you need to study. Because as you see, the most of the question either related to carotid endarterectomy, foramina of the skull, lumbar puncture, something related to thyroid or submandibular gland, because this is common surgery done, thyroid surgery, submandibular gland surgery, and it is important to know it. And of course, to know the foramina of the skull and area of the skull is important because it is a tricky question. Okay. In the few lectures and in the WhatsApp groups, we discussed most of the anatomy topics from the previous exam question. If anyone just joined recently, they unable to access from upper limb, just contact me. We have a channel in the YouTube called Vascular Art Group, and in these channels we put the all recording of my lecture, so you can access it. And also we try to make, we have a channel also called MRCS Malaysia, but it's still we make some modifications, so also you can join it. Okay. Today or maybe maximum tomorrow, I will send to you 108 question. It is basic anatomy. It is question like what is the nerve supply of the sternocleidomastoid, what is the nerve supply of the trapezius muscle. So some simple question, because sometimes you know a lot of details in some disease, but don't know the basics. So it is important to know the basics. Next, now we have pathology. In pathology, we have 90 question. We take it, some of them today, the other we take it next Monday. We don't have this Friday, but from the next week, we have a meeting every Monday and Friday. Okay? I just share the pathology. Pathology question is easy. Pathology also is easy topic in exam, simple. Of course, in pathology, who mainly from surgical point of view, because it is surgical pathology, so he looking for jaundice, gallbladder, cancer thyroid, cancer colon. What is different than what you teach in Malaysia is inflammatory bowel disease and aortic aneurysm, because this is a British exam. The aim of exam to travel to UK, so they ask a lot about some inflammatory bowel disease. Okay. You can find this question maybe the same style you see in your college before. We start in pathology. 12 years old child is admitted with a 12-hour history of colicky, right upper quadrant pain. On examination, the child is afebrile, jaundice. The abdomen is soft, not tender at the time of examination. On investigation, unconjugated or indirect bilirubin is elevated. So what is the most likely cause? So it's a child and the indirect bilirubin is high and no fever and have jaundice. We don't mention the color of urine here, but some version we can mention. So what you expect is this patient have? Anyone?
Hereditary spherocytosis.
Yes, correct. So this patient have hereditary spherocytosis. First, because he's young. And second, they have jaundice. Of course, he don't mention urine, but it means that the urine is clear. But the important topic here is the indirect or unconjugated bilirubin is elevated. So it is hemolytic jaundice, so it is hereditary spherocytosis. Of course, if say direct bilirubin is high and the patient have fever, so it is Charcot-Triad or ascending cholangitis. Okay. Next question. 40 years old woman underwent right hemicolectomy for colonic carcinoma. So they have a cancer colon. Subsequent diagnosis of Lennis syndrome. Lennis syndrome is very rare syndrome. It can be presented by hereditary non-polyposis colorectal carcinoma and another cancer. So what you expect is the other cancer, although it is rare, but they have two cancer. One in the colon, and where is the other cancer? Anyone got the idea? Other cancer in
cancer.
yes, so it is a cancer of the uterus or uterine carcinoma. So uterine carcinoma or endometrial carcinoma and cancer colon can occur both in Lennis syndrome. Very rare, but it is important to ask because you can find in some family have this Lennis syndrome. So one of the family have cancer colon, the ladies can have cancer uterus. Next question, a 32 years old woman presented with tender breast lump. She has 2 months old child. Clinically, she is tender, fluctuant mass in the breast. What's the following appropriate diagnosis? So she is young, she is just pregnant, first baby, and this localized mass. So anyone, what's your diagnosis?
Breast abscess.
Okay, so if mention no mass and it is diffuse redness, so what's your diagnosis?
Lactational mastitis.
Yes, okay.
Yes.
So usually patient, especially for first baby, she is not expert in cleaning in her breast. They have infection. So if it is redness all over the breast, so lactating mastitis or mastitis, if she take antibiotic and become localized, we call it breast abscess and must be drained. So here she is young, lactating, and have a mass, so it is abscess. If diffused redness, tender, painful, so it is mastitis. We don't write mastitis here, but it's okay. 53 years old lady presented with creamy nipple discharge. On examination, she's discharge originated from multiple ducts associating with nipple inversion. So which one of the following is most appropriate diagnosis? So this patient is 50 and have discharge from the nipple. This discharge is not bloody. And we don't mention loss of weight or all this. So what it could be?
Dark ectasia.
Yeah, so duct ectasia, usually the easy way to recognize duct ectasia, you can find the patient is a heavy smoker. Usually in chronic smoker in ladies, old age, have multiple creamy pus and repeated abscess, it is duct ectasia. In the past, we called it plasma cell mastitis. We don't use this term now. In young, we called it subaerial abscess or mastitis also. Okay. But duct ectasia in old. 52 years old lady presented with clear nipple discharge. On examination, discharge is seen originated from single duct. Cytology of discharge show to be contain blood but no malignant cell. Imaging, clinical examination, no obvious mass. Again, mean no mass, no lymph node. So, what's your diagnosis?
Intraductal papilloma.
Yes, it is benign lesion because no malignant cell, but have a bleeding. So it is duct papilloma or intraduct. Duct papilloma is one of the cause of bleeding and must be taken serious simply because this patient is old age and to exclude cancer. Sometimes it's still query. We remove the duct, something called macrodictectomy. We put like a probe inside the duct who have a discharge or bleeding and remove the area around this tube or this probe, and we called it macrodictectomy and send it for histopathology. But at least you need to examine the blood or discharge for cytology to exclude it is malignant. Of course, examine the patient, mammogram, all these can be recognized or diagnose small malignancy. Okay, so as you see, the question is simple, maybe in the level of your medical schools. 2 days old baby is noticed have voiding difficulty and the closure inspection he noticed have hypospadias. It is important to know if suppose this is a penis, hypospadias is down, epispadias is up because epispadias is associating with loss of the skin of the anterior part of the abdomen, what we called it ectopia phthisica. But epispadias is associating, like in this question he asked about, here hypospadias. So hypospadias is associating with cryptorchidism. So if epispadias associating with ectopia phthisica or loss of the anterior abdominal wall, but hypospadias, which is common, can be associating with cryptorchidism. After that, we have many questions about the liver. This is important because now most of the doctor do routine CT, ultrasound. So sometimes the patient found a tumor or vascular tumor, and this vascular tumor is not a tumor, it is just a hemangioma, which is a benign tumor. In the past, the old style contraceptive pill can cause adenoma also in the liver. So all this is not dangerous, but the common liver tumor usually or still secondaries from cancer colon due to portal circulation. And the easy way to differentiate is this tumor is primary liver tumor or secondary, just do alpha fetoprotein. If you make alpha fetoprotein as a tumor marker, if high, it is hepatoma. If the carcinogenic embryonic antigen or CEA is high, so it is cancer colon, have send the metastasis to liver. So we have many questions. One of the habit of the MRCS is they put the same topics and repeat it with different disease, like you see now. So you can find the same question, just a little change. So 38 years old lady presented with right upper quadrant pain, nausea. Her liver function tests are normal. Ultrasound examination demonstrate hypoechoic well-defined lesion. Well-defined, it's not irregular in the left lobe of the liver, measure 14 cm, which is big. But this patient have no other sign. What is the following is most appropriate diagnosis? So it look like something benign. something not affect the patient liver, not affect the patient weight, no loss of weight, nothing is mentioned. So what it could be?
Cavernous hemangioma.
Yes, so it is just hemangioma. You know, it is very common to find hemangioma of the patient. The only important to know is the patient have hemangioma. When you describe to him oral anticoagulant, take care because this hemangioma can be ruptured. Okay, so this is cavernous hemangioma. You can see the same question, the same lady, 37 years old lady, so still young, presented with right upper quadrant pain, nausea. She is on oral contraceptive pill for many years. No ill effect. Her liver function test, serum alpha protein is normal. So liver function test normal, alpha fetoprotein is normal, so no, not hepatoma. An ultrasound examination demonstrate 4 cm non-capsulated lesion in the right lobe of the liver has mixed echodensity and heterogeneous texture. Following is the most appropriate diagnosis. So this patient is not hepatoma and have 4 centimeters, so it's not big size, tumor or mass or lesion in the right lobe of the liver. So first, it is benign or malignant, and you can choose one. This is the heading again. Okay, so this is just liver cell adenoma or adenoma, although it is rare, but can happen. In the past, it's common with oral contraceptive pill. Now it's not common because the pills now is mini pill. It is important, we mention here hydatid cyst, amoebic abscess, especially hydatid cyst is a parasite. All these parasite characterized by something can see in the blood, we see in the next scenario. So 38 years old shepherd. Shepherd is work with animal, presented with clinic with 3 months history of malaise, right upper quadrant pain. On examination is jaundice. Laboratory investigation, mild elevation of bilirubin, transaminase, elevated eosinophil. Abdominal X-ray demonstrate calcification. I saw use CT. In the right upper quadrant of abdomen, what is the following is most appropriate diagnosis. So we can see this picture. If you use the picture, this is the liver, this is spleen, this is stomach. This is a lesion in the liver, but you can see it is thick wall, not irregular, not have umbilicated, not have central degeneration, which is character of the secondaries, and not multiple. Usually secondaries is multiple and have central degeneration. But this patient, the only abnormal apart from bilirubin and amylase is eosinophils. So eosinophils direct yourself there to parasite. So this patient have a parasite because he treated animal or contacted animal, and this parasite caused the complication. So what is the diagnosis now from this picture?
Hydatid cyst.
Yeah, it is hydatid cyst. I in the answer sheet I put the picture of the hydatid. I just have here or in the no, I put it in the answer sheet. I put the picture of hydatid of the Echinococcus granulosa, which is the organism responsible for or parasite responsible for hydatid cyst. Hydatid cyst usually occur if you are contacted animal. Okay. By the way, it's not amoebic abscess because amoebic abscess, although it is a parasite, but not associating with eosinophilia. This is just tricky. After that, we have another type of question. 5 years old boy presented clinic with short stitches suggested achondroplasia. What is the genetic basis of the disease? You know, genetic basis like autosomal dominant, autosomal recessive, X-linked like hemophilia. So achondroplasia is run in family, so it is autosomal dominant defect. In surgery, not like medicine. Medicine have a lot of disease, but in surgery, autosomal dominant disease, we have like neurofibromatosis, familial adenomatous polyposis, achondroplasia is not important also, osteogenic imperfecta in orthopedic. But what is important to us is only familial adenomatous polyposis because can cause cancer colon. Next question is a 58 years old man has been suffering for mechanical back pain for several years. On morning, he awake from sleep and feels sudden onset of pain in his back radiated to his leg. This is typical of disc prolapse. So which of the following event is likely account for this symptom? In the disc, we have central part of the disc, we call it nucleus pulposa, and the lateral part of the disc, which is called nuclear fibrosa, which can be inner and outer. The disc can happen, but no pain, nothing if it is laterally. But the central disc or posterior disc is usually painful and needs surgery. And this central disc is come from nucleus pulposa, from the center. So if the patient have disc and have a pain, so it is prolapse of the nucleus pulposa. But the other lateral and others, it is a disc also, but not compressed on the nerve, so the patient have no much complaint. Can be discovered, of course, in MRI, in CT, but the patient usually have no complaint. Next question, about 34 years old man presented to surgical clinic 8 months following laparotomy of ruptured spleen. He complained of nodule in the center of his laparotomy wound. This nodule, usually it is reaction around the stitch. We called it granuloma. We called it stitch granuloma. So exposed surgically and stitch granuloma is found. So what cell type of granuloma? Granuloma is type of granulomatous disease. It is aggregation of, anyone got the answer? What is granuloma?
Macrophage.
Say again? Macrophage, yes.
Macrophage.
Granuloma is aggregation of macrophage. A macrophage becomes something called the epithelioid cells. Aggregation of it make a circle, we call it granuloma. Of course, in this question, red Stringberg cell, it is for anyone?
Lymphoma.
Hodgkin lymphoma. Red Stringberg, it is the name of two scientists from Germany who discovered Hodgkin lymphoma. Okay. In exam also, you can find sometimes have a table, although maybe a lot of data, but at the end, it will be easy. Because first, they have the normal value. In exam, will give you the normal value. 72 years old man just undergoing emergency repair for rupture abdominal aortic aneurysm. Post-operative, he was taking aspirin, clopidogrel, warfarin. Interoperative received 5,000 units of unfractionated heparin before application of aortic cross clamp. Blood result in the clinical as a follow. Hemoglobin is 8, so it is low. Platelets is low. White blood cell is within normal, not infectious. FDB, fibrin degradation product, is elevated. So the key here, this patient have something related to bleeding. Cause anemia to bleeding is something expected. Cause platelets to become low and elevated FDB. Elevated FDB have, due to blood transfusion and all this, is indication of what? So what is this patient disease? What you expected? Anyone got an idea?
DIC.
DIC. So this is DIC. disseminated intravascular coagulopathy. Of course, it's not due to warfarin, because if due to warfarin, they can affect it, and they can mention that INR is affected, prothrombin time is prolonged. So anastomotic leak also can cause leukocytosis, and usually anastomotic leak occur after 5 days. So it is just DIC, disseminated intravascular coagulopathy. We have some disease maybe not common in Malaysia, like this picture. Sometimes in exam we have picture also. 23 old man presented to surgical clinic with a hernia. However, you also notice that pigmented spot around his mouth, his palm and the sole. His history, he's underwent reduction of the intussusception at age of 12 years. Colonoscope found multiple polyp. What is the following lesion? So this is a picture of patient. If you see this patient, they have a pigmentation in the around his mouth, pigmentation in the buccal mucosa, can be also inside, and history of multiple polyp, and the patient is 23, so he's young. So it is not a cancer. It's not a cancer, but have pigmentation, have multiple polyp by colonoscope. If you dissect the small intestine, also you can find multiple polyp. So this patient have multiple polyp in small and large intestine, have pigmentation around mouth or buccal mucosa. So this is, what is the name of disease? The name of disease is not mentioned here, but what is this disease called?
Peutz-Jeghers.
Yeah, Vagus. Yes, it is Peutz-Jeghers syndrome, and it is not a tumor and do not turn malignant, not like familial adenomatous bullosis. Familial adenomatous bullosis, autosomal dominant disease, can cause cancer colon. But this patient, Peutz-Jeghers syndrome, is hamartoma. Hamartoma is tumor-like, so it's not a tumor. It is abnormal or puzzle or bizarre arrangement of the cell. We called it hamarton or hamartoma. So it is easy and simple. So just to see the picture, maybe not common in Malaysia. Again, it is important to recognize that this is a British exam, so something maybe not related to your culture. 56 years old surgeon. So he's surgeon for many years. Is not first time go to theater. Over the past few weeks, she has noticed that his hand or her hand becoming blister and the whippy, a latex allergy is diagnosis. So this patient or this surgeon or this lady, she work in surgery for a long time and suddenly become allergic. So this is easy, because if this is the first time I wear gloves and have this, so it is type 1, which is called anaphylactic type of hypersensitivity. But if occur after many, many, many years, what we called it?
Type 4, delayed hypersensitivity.
Yeah, so it is delay hypersensitivity reaction. So it is important, if I mention patient come first time and he insert a catheter in the emergency and has a reaction or edema and low blood pressure, so it is anaphylactic type 1. But if the patient used to do this technique or used to have a gloves and suddenly become worse, so most probably it is delay hypersensitivity reaction, which is type 4, which is related to cell-mediated immunity. Because as you know, type 1, type 2, type 3 is humoral immunity. All antigen antibody reaction, B lymphocyte. But delay hypersensitivity is usually due to T lymphocyte. We called it delay hypersensitivity reaction. 43 years old man presented with hemoptysis and diagnosed as having TB, tuberculosis, which cell type listed for granuloma. So he need to know this patient have TB granuloma. So what type of the cell? As we mentioned before, it is macrophage. Okay. Next topic is important to us in exam, and also you can find also in undergraduate, is the tumor marker. Tumor marker is very, very, very important topic. Of course, you have a lot of tumor marker, but the important is what is tumor marker related to surgery. So, which this tumor marker helpful to identify a patient with hepatocellular carcinoma? So it is easy. Anyone can answer? Anyone?
AFP, serum alpha fetoprotein.
Alpha fetoprotein. So in this, if you see this question, so it is important to know. So CA99, it is for cancer what?
Pancreas.
Pancreas. Carcinogenic embryonic antigen for cancer? Colon.
Colon.
Beta human gonadotrophin for choriocarcinoma can occur in the female uterus, can occur in the testis. CA125 is for cancer ovary. So it is important. We found the question like this. Not, of course, you know the answer, but it is important to know what is the other, what is the other, what is the other, because it is easy to change the question and ask you about if this patient have a cancer head of pancreas, what is the tumor marker? Is CA99. 45, old lady recently undergoes hysterectomy for treatment of medullary thyroid carcinoma. So what is the tumor marker of medullary thyroid carcinoma? It is, anyone?
Calcitonin.
Calcitonin. And it is important, if I read about medullary thyroid carcinoma, I found it can be part of multiple endocrine neoplasm type 2. And this multiple endocrine neoplasm type 2 also associating with pheochromocytoma. And the pheochromocytoma have two tumor marker, one in blood, which is metformin, and one in urine, which is phenylmandelic acid or VMA. So again, if you find question like this, so just to go to Google or go to your reference or basic surgery for MRCS to know what is multiple endocrine neoplasm type 2. So it is related also. 43 years old lady, hypertension, suspect to have pheochromocytoma. So what is the investigation or what is the tumor marker? So what is this? The answer is
Urinary vanilla mandelic acid.
okay. So here also, apart from the other because related to medicine, but the only related to surgery is urinary 5-hydroxyindole acetic acid or 5-HIA. This 5-HIA, it is a tumor marker for a rare tumor in appendix. What is this tumor? 5-HIA, HIAA. It is tumor marker. It is the end product of serotonin, and it is a tumor marker of the carcinoid tumor, which is a rare tumor, can occur in the tip of appendix. Okay, so this is urinary 5-indole acetic acid. But the answer of this question is phenylmandelic acid or VMA. It's come many times. Okay, next question. Which one of the following malignancy diagnosed by raised alpha fetoprotein? Of course, we mention alpha fetoprotein in hepatoma, but hepatoma is not mentioned here. So what is other tumor alpha fetoprotein is raised? What is the answer?
Donkey, non-seminomatous testicular cancer.
Okay, so it is non-seminomatous testicular cancer. Some books they call it Yuxac tumor, some call teratoma. Of course, this is all non-seminoma because seminoma have no tumor marker. Okay, again, which of the following malignancy diagnosed by elevated 99? Of course, in this question, it is important don't see the answer. You know the answer in your brain. So elevated CA99, so it is what? Easy question. Anyone?
Pancreatic cancer.
Pancreatic adenocarcinoma or cancer. So next question, still in tumor marker. What one of the following malignancy diagnosed by elevated alpha fetoprotein level in 45 years old woman? So it is woman, so it is not testicular tumor. Of course, we don't put an option. So what it could be? What is the answer? Anyone?
Hepatocellular?
Hepatocellular carcinoma, it is hepatoma. So again, tumor marker is easy, simple, all or none. And again, pathology is very easy in exam and simple. And it is easy to have a mark from the pathology. After that, we still have 10 questions, so don't worry. Just 15 minutes, we will finish. Renal stone. Of course, we have a lot of renal stone like calcium oxalate, uric acid, cysteine, sterophyte, and calcium phosphate. By exclusion, cysteine is occurring in baby because it is cysteinuria. It is a metabolic disease. But uric acid can occur in any gouty patient, if patient have a gout, or in other condition as we see in this question. 73 years old lady undergoing chemotherapy for the treatment of acute leukemia. Whatever the chemotherapy she take, she develops symptom of renal colic, urine test positive for blood, QBI X-ray, which is not common done nowadays, no stone. Usually nowadays we don't do X-ray because some stone like urate stone or uric acid stone not appear in X-ray. So the guideline we start by ultrasound, abdominal ultrasound, or of the patient when known have stone, we start by CT with dye. So this patient have chemotherapy. As we know, chemotherapy destruct the purine and the DNA or amino acid which contain purine. So one of the cause of high uric acid, apart from gout, apart from eating red meat, apart from eating alcohol, is chemotherapy. So this patient have uric acid stone. Why uric acid stone? Because uric acid stone not appear in X-ray. Okay, and it is related to chemotherapy. Cystinuria is not the answer because it is not a baby. If you see the next question, so here is different. A 6 years old boy presented with renal colic. The parent both have similar history of this condition, so something run in the family. So it is metabolic disorder. Urine test positive for blood, plain X-ray or KUP X-ray show relatively radiodense stone in region of mid-ureter. So they have a stone. This is stone appear in X-ray, so it is not uric acid stone. And this is young and the running family. So the answer here, it is metabolic disease or metabolic disorder, and it is cystinuria. So cystinuria is the only cause of stone in young people. Young mean baby. It is the same like gallbladder stone in baby can be due to hemolytic anemia. Okay, next question is still in stones. 43 years old lady, episode of recurrent urinary tract sepsis, presented with stag horn calculus at the left kidney, urinary pH 7.6. It means that the urine is alkaline. Normal urine is acidic. Plain X-ray show faint outline calculus, so they have a stone. Which of the following is most likely urinary tract stone type? So the key here is which stone appear or which type of stone appear in acidic in alkaline media. So of course we know in the alkaline media we have a bacteria called the Proteus, and this is Proteus can cause staghorn stone, and this staghorn stone usually combined or the content is something called sterophyte. So staghorn or sterophyte usually occur in the alkaline media due to Proteus infection. So the doctor now, what he need to do, he need to make acidification of the urine. So need to make the urine acid again. So of course we don't give the patient hydrochloric acid or sulfonic acid because it's dangerous. So what is medical material or tablet can give to the patient cause acidification of the urine and is not dangerous? Anyone have an idea how to give the patient something to make urine acidic? Which vitamin we can give him make urine acidic, or which vitamin is acid?
Vitamin C.
Vitamin C. Okay, so you can find some patient, he take vitamin C big dose is not because he have lack of vitamin C. It is the doctor, they need to this excess vitamin to be excreted in the urine. So the urine become acidic, so they kill Proteus infection or Proteus bacteria, and it is prevent further staghorn stone, but of course this stone already formed, they need to be destructed. Next question, we have some tricky question. Pathologist is examine histological section, identify something called Hassel corpuscle. So this Hassel corpuscle is occur in which organ in the body? If you remember histopathology or histology, so this is Hassel is normal pathology, normal histology. So it is found in which organ? Of course, not the kidney. Nephron, the kidney is not like this. Not the stomach. Not thyroid. So this is thymus. So why we ask about thymus? Thymus is important because we have an operation called removal of thymus gland in medical disease. Anyone know what is medical disease occur in female and the treatment is remove thymus gland? Anyone have an idea?
Myasthenia gravis.
Myasthenia gravis, yes. If the patient have, ladies, young girl, have weakness of the muscle, something called myasthenia gravis, which is antibody against acetylcholine receptor, one of the treatment option is removal of thymus gland. It's done by cardiothoracic surgeon. So this is why he asked about thymus gland and this Hassel corpuscle. After that, we have some general questions. 32 years old man involved in house fire, sustained extensive burn in his torso and thigh. 2 weeks post-operative, he developed bilateral lower limb edema. So this patient have lower limb edema after burn. A bilateral lower limb means that it is something systematic. Like for example, if you see the patient have bilateral lower limb edema, can be renal cause, can be cardiac cause, but in this patient, what is the cause? Anyone have an idea? Think simple. It is a simple idea. Have a burn, he lost a lot of plasma. So what happened to the patient? Of course, the DVT never occur bilateral. If you give a lot of fluid and the kidney is okay, so you don't cause edema. Idiopathic DVT also, it is not bilateral. So this patient have hypoalbuminemia. If you have loss of plasma due to burn, so the albumin is low. This is one of the indication, you know, in burned patient, if albumin is low, we give albumin. If hemoglobin is low, we give blood. So this patient have hypoalbuminemia. Okay. Next question, as you see, is longer question, but at the end he asked about something easy. 22 years old man kicked in head during rugby match. He's temporarily confused but regained conscious. Half an hour later develops lost speech, ataxia, loss of conscious. On arrival to hospital, he's intubated, ventilated, CT performed, show extradural hematoma. Which one of the following structure lacerated likely to cause? So he just asked if the patient have extradural hematoma, which artery is affected, and the answer is anyone?
The middle meningeal artery.
Middle meningeal artery, and again you need to remember that middle meningeal artery go to the skull through foramen spinosum, and it is one of two terminal branch of maxillary artery. Okay, this question is very common, come in every exam. For me is look strange, but I ask the ENT, Dr. Nabil, he say it is common to we practice. A baby is born by normal vaginal delivery at 39-week gestation. Initially, all appear well. Then the baby develop recurrent episode of cyanosis. This is worse during feeding and improve dramatically with the baby cry. This is the only condition if the baby crying, cyanosis is improved. Because usually pediatric, they know cyanosis can be part from cyanotic disease like phallotetralogy and all this. But in phallotetralogy, the patient become worse in crying. So anyone know what is the condition makes the cyanotic patient improve by crying?
A bilateral cranial atresia.
Yeah, yes, correct. Although it is strange, but they found in colonial atresia, if bilateral, if the patient improve, is during crying. So it is a tricky question. I think is difficult, but of course it is not followed because followed usually have pulmonary stenosis, have a murmur, so something else. This is the last question. 20 years old man involved in RTA, road traffic accident. Following incident is unable to extend the wrist. However, he's improved over the following week. If we cut a nerve, the patient not improve because the nerve regeneration is difficult and they need to reconnect it again and may be not improved. But this patient have paralysis of the nerve. After that, the nerve will improve. So, of course, because it is extensor, so it is radial nerve. But what is this condition called? Neurotemesis is cutting the nerve, so it is not cutting the nerve. So what it could be?
Neuropraxia.
Yes, so this is a case of radial nerve neuropraxia. Neuropraxia is occurred due to compression of the nerve. The nerve is paralyzed temporarily. After that, regeneration is occurred because neurolimbar sheath is intact. Okay, this is the end of today. So again, what I need to tell you, as you see, the question is not difficult.